wanted to follow up on my post about what the American Academy of Pediatric Dentistry put in their, it's really on their website and it's embedded in the guidelines and recommendations. So when I look at the guidelines and recommendations and management of how to manage a child with malocclusion, oral habits, this is what they're explaining now, this is what they're talking about. So in this first section, you'll see them present the problem. So the problem is, how do we manage kids that we notice malocclusion on? And really what they're saying overall is, be aware of the habit, be aware of the causation of the malocclusion. So what I have a problem with is it's not alluded to that possibly other things can cause malocclusion, not that malocclusion causes this, if that makes sense. So when you see this first section of the article, they talk about, be aware of oral habits, make sure you know about the frequency, intensity, and duration, talk with the family, talk about informed consent, and then prioritize treatment options. Behavior and compliance is also a big pivotal key in this, which we all know, and then collect data. So all of this data that they're talking about collecting is what we do in our practice. So we're looking at the position of upper and lower jaws. We're looking at transverse growth or deficiencies with the width or the widening of the palate and anterior and posterior. That they're looking at or taking in all the data to make the right treatment plan, right protocol, all of the things. The other thing that's what I've noticed that's they've added or discussed more is this cone beam, is the CBCT. What I feel is super valuable about patients that or practices we work with that have this is we hear a lot about referring out to ENTs, refer out to ENT with these airway cases. But if you have a great orthodontist that's educated in airway and the importance and the value of that when they treat their patients, and they have a CBCT at their office, we can send them in, have the CBCT done, and really look to see if there's other pathology or anatomical factors that are contributing to what we're seeing symptomatically with airway issues, sleep issues, all of those things. So I like that they put that in. So going back to organizing the diagnosis and providing and implementing a good solid structural treatment plan is what they're discussing, and what they're referring to is going back to prioritizing what needs to be addressed first. So what I like they're discussing is the contributions of the soft tissue and structure to the patient's malocclusion. So soft tissue, muscle, how that influences somebody's arches, dental arches, teeth, and jaws to grow or not grow. So what I like how they write in the language is really establishing a good sequelae, if you will, of prioritizing treatment. So what does that mean? So if we know that most kids or people are going to need some type of expansion. That's just what we're seeing and dealing with in this field, working on airway, tongue space, oral resting posture, all of those things. But I will prioritize seeing orthodontist or structural intervention over soft tissue and muscle if somebody that knows how to look at x-rays or has records sent over and they come here first and I see that I'm looking clinically and I don't see lateral incisors. All I see are central incisors, permanent, and primary canines, and there's no room for the laterals. And I look at their periapicals or look at a pano, and they do have lateral incisors present, but they're completely blocked out. Go see the orthodontist. Get the structure addressed first, because there is a chance that they can lose the permanent teeth that they have in from the migration of the lateral incisors trying to find a space to drop out, and it'll resorb the root of the other permanent teeth. So that's prioritizing care. Now, further down in this literature is talking about the interventions and when to take them in what dentition stages. So the treatment options and treatment interventions, it does talk about primary dentition. So once again, if you remember, that's around age 1 or 2. And when we talk about treatment in that stage or that age, it's definitely doable. It just looks different. So therapy that's provided, referrals that are provided to a therapist, not necessarily would be called a myofunctional therapist. It would be either like a speech pathologist, an occupational therapist, somebody that is skilled on the function of the oral facial complex, skilled on airway, skilled on feeding, skilled on sensory, because that's all going to be huge in this population in addressing all of it. It's not just about muscle reeducation, it's about addressing what adaptations and compensations that age group has developed. It's easier to unblind. Also, it's important to point out that in this primary dentition stage, they are talking about if there's airway problems, that should be a red flag to the provider to discuss further options and further intervention. So it's not just about occlusion anomalies, the sequelae of eruption, but it's also if there's airway problems present. So practitioners or clinicians that are working in a pediatric office, hopefully they have some type of screening system in place, albeit on their medical history or their intake forms, that has questions, or a pediatric sleep questionnaire. That would be great. Talk about bruxism, and then what I like about how they pointed out the bruxism, I haven't seen this before, is they also talk about that bruxism could be possibly associated with sleep issues, breathing issues, which I haven't seen that before. Let's see. What oral habits, non-nutritive sucking, long-term non-nutritive sucking, and the association with that. And they talk about that changes resulting from sucking habits persist past the cessation of the habit, and it absolutely does. So if you have a thumb habit or finger habit or passy habit, that tongue hasn't learned how to functionally or appropriately rest, swallow, movement for speech patterns, all of the things. So it's suggested that early dental visits provide parents with anticipatory guidance. So that's just a big fancy word to discuss how to counsel these families on what's appropriate and what guidelines that have been, I would say, researched and evidence-based in regards to keeping your oral health optimized. More about malocclusion and mouth breathing. So mouth breathing suggests that impaired nasal respiration may contribute to the development of increased facial height, so the face will grow vertically, and it can open the bite, it can increase the overjet, so how far the teeth come out from the bottom teeth, and the narrow palate butt is not the sole or major cause of these conditions. The cause is the mouth breathing. Those of us who also have some breathing certifications to re-educate with breathing exercises and breath work and awareness, and then of course we would refer as case dependent, but looking more into that from a specialist point of view, so it takes it out of the pediatric dental office's hands. Like, you want to refer to a specialist. If you don't know enough about that or how to help them, refer. And I have to say, ENTs, they are great surgeons, but I haven't met one that's great on being a detective to find out the why and find out how to re-educate the body after the source or the causation of the mouth breathing is removed. So that's why therapy, even if surgery is warranted or needed, is really beneficial to optimize the outcome of why you're doing the surgery to begin with. So then they go on to say OSA may be associated with a narrow maxilla, crossbite, low tongue position, vertical growth, increased overjet, and overbite. History associated with OSA may include snoring, sleep apnea. So all of the airway, all of the sleep is being discussed in here. They talk about bedwetting, they talk about sleepiness, and why did we get the narrow maxilla? Why do we have the crossbite? Why do we have a low tongue position? So when we're already seeing obstructive sleep apnea or sleep disorder breathing, seeing malocclusion early on, we may be able to prevent full-blown OSA, not just the teeth crowding component. It's the sleep and the sleep disorder breathing, obstructive sleep apnea, and the effects that it affects the kids with. Or they're just going into more of other components of symptoms or things that might come up that might cross over with mouth breathing and sleep apnea. So long faces, enlarged tonsils, hypnasality, voice quality, like you just say they just sound congested, mandibular retrognathia, so the jaw is set back, and that's going to set back into the airway. Larger tongue, but is it a larger tongue or is it a small oral cavity because the tongue wasn't up in the palate? Hypoplasia of the midface, so the midface or the maxilla didn't grow as much as it should, and this maxilla right here, this maxilla is what houses our airway. It's everything's in there, our nose, all the things. It houses most of our airway. So we can see this early is my point. And so they go on to identify all of these things, manage and refer. So anticipatory guidance on a long-term sequelae should be provided an intervention to terminate any of those oral habits. So like the mouth breathing, the low tongue posture, the tongue thrust, all of those things. So it's a long-term sequelae of management. And so when we see the younger kids, I never want to let them go completely, even though they've made their goals, because I want somebody to be their voice as they grow and guide them into the growth and make sure they've kind of checked off all of the things that we can do to intervene on the symptoms they presented with initially. And so then they talk about the language that they use is management of oral habit and the recommendations to manage all of the things and all the things they talked about in that sequelae or that timeline of interventions would be, which is what I love, is habit treatment modalities include counseling the patient and the parents. Love that, because if our pediatric dentist and their team are saying the same things we are, gosh, isn't that a beautiful world? And these parents are not getting he said, she said, and I'm confused. This is so much information. And then behavior modification. So, do we go to bed with a sippy cup? Do we go to bed with a thumb in the mouth? Things like that. But I say, take that off the pediatric dental office slate and refer over. So refer to an airway orthodontist. Psychologists, yes, they have a great role in all of this. But typically the orofacial myologists are going to establish the care plan, establish the team, and collaborate with those other providers. But the fact that they put that in there, my gosh, I love it, because I haven't seen that at all. It's usually just appliance-based and sent to an ENT or an ortho. So myofunctional therapy is getting a shout out, it is getting attention, it is being discussed, and it isn't a recommendation from the American Academy of Pediatric Dentistry. I love that. So this is super long, but I really wanted to go into more detail because I feel like it's very valuable for all of us to understand this language, learn it, whether you're a professional or a family member, a parent, grandma, auntie, whatever. But yeah, so I love that this language is in there. I love that they're discussing airway and sleep and oral habits and all the things, and hopefully that we just talk about this more and we get more eyes on these kids' mouths so they get help earlier, and we don't see all of these complex conditions, kind of like what I went through, if you know my story, and we get earlier intervention, and that's where it's at, baby. That's where it's at.